Next is Dr. Bret Peterson, hand specialist at OCR, and he's awesome. Yeah. Good job, buddy.
Good morning. My name is Bret Peterson. I'm one of the hand and upper extremity specialists. Many of you I know. Thank you for coming today. So my focus today is on athletic injuries of the hand and the wrist, and specifically understanding kind of the nuances in addressing this patient population, whether it's adolescents all the way to the weekend warrior or the professional athlete. Good. Okay. Nothing to disclose. Our goals today are to discuss some of the more commonly seen athletic injuries of the hand. And that being said, you're going to see a little bit of a buffet. We won't dwell on any of them too much, but at least get some overarching principles in management. We want to understand the basic principles of treatment and get familiar with some of these differences that depend on an athlete's age, their current and potential level of play, what sport they play, their position, what their role is on the team, perhaps their hand dominance, and are they in season or out of season. That will guide what you're going to offer them. And then one of the most challenging aspects of this is navigating the dynamics between the athlete, the provider, the coach, the trainer, etc. We will look at several of these, perhaps not all of them, but we see a lot of typical hand and upper extremity traumatic injuries and overuse injuries, and we'll discuss some of those. The scaphoid fracture is typically a fall on an outstretched hand. It's the most commonly injured wrist bone. And sometimes these present somewhat underwhelmingly. They may present as a sprain. They may have some radial-sided pain in their wrist, but certainly axial loading can be uncomfortable, or they may have an extreme portion of the bone that's broken at the proximal pole or at the scaphoid tubercle. So snuff box tenderness is one of the key findings. Most patients will have this, but just because they don't have snuff box tenderness doesn't mean they don't have a scaphoid fracture. They may have tenderness at the tubercle on the palmar side, and you may be able to elicit discomfort with compression or axial loading of the thumb. Imaging would be standard in diagnosing this, and we would typically get an AP, lateral, perhaps an oblique, and typically dedicated scaphoid x-ray views. It's important to know and to keep in mind as you're treating these patients that up to 30% of these non-displaced scaphoid fractures will not show up on your first x-ray. And so it takes a high degree of suspicion to treat these appropriately, and it may take a week or two for that x-ray to become positive on the non-displaced scaphoid. How this applies to an athlete is you're probably more likely to get an MRI early because we can tell within 24 hours of a scaphoid fracture on an MRI if there truly is a fracture there, whereas you may not see it on that first set of x-rays. And that matters in terms of time. If we have an in-season athlete and we're contemplating a sprain versus a scaphoid fracture, we want to know that early so that we can accelerate care if it's just a sprain. Treatment is going to depend specifically on fracture location, how displaced it is, where the patient is in the timing of their season, or the weekend warrior if it's winter or summer, what position they play, and the timing within their career. There's a big difference between treating an 11-year-old who has ample time or a pre-collegiate late season senior in high school. We typically will fix this for any displacement over 1 millimeter, perhaps less in an athlete. Perhaps we'll place a screw because there have been studies demonstrating that we can get an athlete back faster, perhaps, by fixing it. Certainly a proximal pull is much more likely to be fixed, such as this CSU defense player, because these tend to go on to avascular necrosis or non-union at a much higher rate because of their blood supply. Many fractures can be treated in a cast, and if a patient is out of season or it's a young patient, a cast is a very suitable way to treat a non-displaced fracture. There is not consensus or definitive evidence that a long arm cast is better than a short arm or is better than a thumb spica. personal preference, I typically will put these patients in a thumb spica initially, and if we need to continue casting, I'll transfer them to a standard short arm cast, but there's not definitive superiority evidence in the literature. If we move to surgery, we'll typically use a headless compression screw, as you see here. But there's an assortment of options, whether it's plates, screws, wires, and even for a non-displaced scaphoid fracture, sometimes we'll fix these to get an athlete back faster if they're a high-level player. Scapholunate interosseous ligament tears typically are also seen from a fallen and outstretched wrist. These patients may present subacutely several weeks after, just assuming they have a sprain. They may have a history of popping or clicking with activity, and they may describe a dorsal central wrist pain. A useful test for this is the Watson shift. Now, the classic description of this is going to be pressure over the scaphoid tubercle with radial to ulnar deviation. And in theory, if you have an unstable scapholunate interval, that's going to allow the scaphoid to ride out dorsally up onto the radial rim. In practice, we don't always see that because there are many different flavors of scapholunate tears, and if you do have a true clunk on these tests, it's probably a pretty severe and pretty unstable wrist. In my own practice, I think this is a more useful test in that if you do the Watson shift, you may have the patient experience pain over the dorsal wrist as you're doing the radial deviation. It may not clunk, it may not click, but if they have pain dorsally, that's positive for me. On radiographs, a severe unstable injury will have more than 3 millimeters of scapholunate widening, as you can see here. You may also include a stress test if you are suspicious of a scapholunate injury. Not all scapholunate injuries have static diastasis. Some of them are dynamic, and that's because of the contributing roles of extrinsic ligament stabilizers and even muscular stabilizers. Sometimes we'll get a PA grip view, which I personally prefer in these situations because I can then see the contralateral side. There are some variances in human morphology. Some patients are naturally a little bit wide, but we can see what normal is in this situation. And then we can see as they put stress through the carpus with a clenched fist, we can see if they're going to widen, and that would be a dynamic injury. If plain radiographs are not illuminating, you may consider an MRI. This is when it becomes a little bit more helpful to kind of understand what the normal anatomy is of the scapholunate ligament. You can think about it as a U, and between the scaphoid and the lunate, there are 3 components really. There's the palm side, the volar component, there's the proximal part, the bottom of the U, and there's the dorsal component. And so biomechanically, we think that the dorsal component is the most important. And most of the time, if we're reconstructing or repairing, we're targeting the dorsal aspect of this. Now, this is somewhat controversial, and in fact, there have been over 250 articles about the scapholunate ligament in the last 4 years. So this is constantly undergoing more biomechanical investigation. But an MRI lets us see this. If there's just a membranous tear on the bottom of the ligament or the volar component, that may be amenable to non-operative treatment. A dorsal tear may be more of a problem. And many times when we say you have a wrist sprain, this is one ligament that would contribute to that. So this may just be a sprain that gets better. A patient may have what we call the pre-dynamic scapholunate tear. That might be 1 or 2 components of that U-shaped ligament. Typically a short time of immobilization, perhaps some therapy for wrist extensor and flexor stabilization training, and a lot of times we can let some of these athletes play in a brace or cast depending on what their particular role is. It can take up to 3 months for these symptoms to settle down, and one of the challenges with such a biomechanically complex ligament is that they may have chronic or repeat aggravations that cause wear and degeneration that leads to problems in the future. Complete tears, or tears that are persistent for several months and resistant to conservative treatment, may need a wrist arthroscopy. There's a variety of ways of addressing these based on classification systems and diagnosis intraoperatively. We may be able to just debride the irritated component, and that may be enough that patient does well. While thermal capsular shrinkage may have fallen out of favor in the shoulder, it seems to be a viable option for some types of scapholunate tears in the wrist. For more significant tears, we may pin it, we may do an open repair, or we may even need to use a tendon graft and perform an autograft reconstruction. For these, we try to get to an unstable scapholunate tear early, because if you have to reconstruct it because the ligaments of poor quality on a delayed basis, the outcomes are more unpredictable, the wrist is stiffer, and the grip is weaker. This is a 48-year-old tennis player who had an awkward backhand, and he just assumed that he had a wrist sprain, came in about 6 months later, and as you can see, he's widely diastased. And this implies not only complete rupture of the scapholunate ligament, but also some of the extrinsic ligaments that help stabilize that. So he required a complex reconstruction with bone tunnels, autograft tendon that we incorporated, and temporary pinning for about 8 weeks. So he's on a long road to recovery, but this should give him a better wrist than he came in with. While you may not see as many of the scapholunate injuries, certainly your practice will see a multitude of overuse tendinopathies, which could be the first compartment, like in this picture with the Quervain syndrome. You may see an intersection syndrome in rowers, where the wrist extensors and the thumb abductors intersect, or FCR tendon on the volar side. Really, any tendon is subject to an overuse tendinopathy in the hand and wrist at times. As you all know, we try to treat these conservatively with immobilization, perhaps some stretching, some therapy, ice, anti-inflammatories, and avoidance of the offending activities until things are getting better. There is a role for steroid injections, not indefinitely, but 1 or 2 if it's helpful. We typically do not see tendon ruptures in these smaller tendons, particularly if you're not injecting them into the tendon but around the sheath. That's a safe thing to do. And for the more recalcitrant versions of this, we will perform a surgical release or tenosynovectomy at times. The ECU tendon is more commonly aggravated in racket-type sports or baseball or hockey, and you may see a full spectrum of tendinitis or more degeneration. You may see subluxation, where the retinacular sheath that houses the tendon has been injured, and so then that tendon slips and pops. You may see a frank dislocation in a hockey player, or you may see complete rupture at times. These patients typically present with pain on the ulnar side of their wrist. They may be tender on the ECU proper. Resisted extension and ulnar deviation is telling, and if you have instability of the ECU, you may see snapping with circumduction of the wrist. I think a useful test for this is an ECU synergy test, and this is a supinated hand when you ask the patient to abduct their thumb and fingers, and you try to close the thumb and middle finger. If that reproduces pain over the ECU, there's likely some degree of tendinopathy or injury in that region. X-ray is useful to rule out competing etiologies, such as a fracture, but an MRI may be more useful for an ECU tendon injury that you think might be more than just a mild tendinitis. You may see tenosynovitis, a degenerative tear, or injury to the actual ECU subsheath. One word of caution when you're reading or interpreting MRIs, many times the radiologist will call ECU subluxation or dislocation. And there is actually a wide variation in the way that groove it exists in humans. And so they will typically call it outside the groove or slightly subluxated, but that tendon is dynamic, it's going to move, and it depends on the position of imaging. So I think, at least in practice, you have to interpret that with caution based on how the patient actually is presenting to you. Ultrasound can be useful. It will show inflammatory change, fluid or tear, and can give you a dynamic assessment of what's happening. As with other tendinopathies, we typically start with immobilization and rest. Putting that tendon in a position of low stress, such as wrist extension and ulnar deviation, is helpful. And once that's feeling better, isometric and eccentric exercises and consideration of a steroid may be necessary. If a patient's not improving or you identify something more significant than just a tendinopathy, sometimes we would immobilize above the elbow to remove that rotational component. If there's an acute frank tear of the retinacular subsheath and the tendon is flopping around, if you catch it quick, you might be able to treat him in a long arm cast. For an athlete, it's probably more predictable to just proceed straight to surgery for that. And if you have longitudinal tearing that's not getting better, you may move forward with repair or ECU subsheath repair and reconstruction. But that's kind of a long haul recovery, and so obviously we try to avoid that if possible. Another cause of ulnar wrist pain is ulnar abutment. For this, we really need to understand the native architecture of the wrist and kind of understand where the ulna sits in relation to the radius. Most patients are somewhere around what we call ulnar neutral. And in a radiograph like this, the ulna just comes right to the edge, the lower edge of the radius on the proximal side. And when we look at the mechanics of this kind of a wrist, about 80% of load transfer occurs through the radiocarpal region, and about 20% occurs on the ulnar side. If you change that ratio, and if you increase the ulna by about 2 millimeters, you're going to increase the load transfer to about 40% on that side. And that matters in someone who's performing repetitive activity or has an injury. So there are normal anatomic variants. We also see change with dynamic movement, gripping, and pronation. And sometimes your young gymnasts will come in ulnar positive, and many times this is because you have repetitive impact on a weight-bearing limb that causes physeal stress over time that may arrest the growth or slow the growth of that radius, and you get relatively longer and faster ulnar growth, all of which increases ulnar load. These patients may have an insidious onset. It's important to be checking for their activity levels, and many times repetitive pronation or ulnar deviation will contribute to this. They may be tender at the lunate or the fovea, and ulnar carpal stress test is probably the most important, as in this picture here. We get x-rays, of course, to look and see what their variance is, to look for ulnar positivity. If there's a question about some of the dynamic components of their activities, you can get a pronated and maximum stress grip view, which can be helpful. And MRI really is helpful for this too. For a more significant ulnar abutment syndrome, you're going to see edema in the proximal ulnar corner of the lunate. You may see associated TFCC tear. You may see chondral injury or lunotriquetral tears. This is a local high-level gymnast, adolescent female who presented, and you can see she's actually ulnar positive on both sides, but she really was struggling on the left side. She had a history of pretty persistent radially sided wrist pain for several years that would be treated with rest and casting, and then when she presented with left wrist pain on the ulnar aspect, this x-ray really was very revealing. You can see the ulna became more than 4 millimeters positive. She had extraordinary stress going through the ulnar aspect of her wrist, and she was a mess. She really couldn't do much with that hand anymore. MRI was still pretty interesting because you can see that the radial physis is still pretty hot, even though she hasn't been able to do much, and the real pain is on the ulnar aspect. So in season, these patients may be able to be treated just by trying to get them to cool off and immobilize and limit the irritating activities, of course, NSAIDs, perhaps a steroid injection. But if these patients are out of season and they're definitively ulnar positive, they're probably going to need ulnar shortening if they want to continue their sport. We usually accompany that with arthroscopy, although not always. Sometimes it's pretty obvious all they need is the shortening. The TFCC may have concomitant injury that needs to be debrided or repaired, but the real crux of this is to shorten the ulna. And that's what we did with this athlete. We took about 5 millimeters out of her ulna, to match the ulna to the radius. The issue here for her was that her radial physis was really pretty done. She was about 13, and her ulnar physis was still wide open. So we can go ahead and shorten the ulna, but it's going to keep growing. So we knew that she didn't have much more growth. We looked at her other growth plates, kind of calculated how much time she had left to grow based on Menzies and skeletal growth plates, and we performed an epiphysiodesis, and basically just you stick a drill in the growth plate and scramble it, and then it heals across, and she no longer grows there. That allowed her to get back to gymnastics, and she's been competing well ever since. You may see TFCC injuries on the ulnar aspect. We know that this is a joint stabilizer for the distal radial ulnar joint. It acts as compression and almost a little disc, like a meniscus for the distal ulna. And we'll see this more frequently in racket sports or baseball or golf. It can be associated with a distal radius fracture. It's actually quite frequent with distal radius fractures, but they typically will improve with time in the healing process. So these patients also have pain in the ulnar wrist, maybe some clicking, they're tender at the fovea, and the ulnar stress test or ulnar deviation test will also be uncomfortable. MRI is very helpful for this. You may see enhancement or edema in the TFCC. You may see linear split, and you may see effusion where some of the joint fluid is leaking down between the distal radius and ulna. If these patients are in season and they're stable, meaning that you can perform a shuck test and you can't dislocate the ulna, we can treat these conservatively with bracing and the standard treatment offerings. For patients that continue to have pain, they may need arthroscopy, they may need repair or debridement depending on the location of the tear, and certainly anybody with instability from the outset needs to be repaired if they're an athlete. On a rare occasion, we'll catch an athlete with a frank TFCC tear that is not unstable, but because of their position or their limitations, we may treat that acutely and with repair, but I'd say that's pretty rare. Peripheral tears are typically amenable to repair. They have a good blood supply there. It's like a meniscus in the knee, and these will heal if they're appropriately reduced and sutures are placed across. We can do this open or arthroscopically. The central or the radial tears typically don't have a good enough blood supply. That tissue is wispy and thin, and it really is not going to do well. But fortunately, if you clean up the loose edges of these tears, most of those patients will do pretty well. It's important to be understanding the ulnar length in these situations because they may be prone to recurrent tears if they're ulnar positive. So you might consider an osteotomy. These patients, if they just need a debridement, they're going to get back to their sport much more quickly. A short time of immobilization, range of motion, some strengthening after week 6, and probably somewhere between week 6 to 12, return to play without restriction. The repair is a different matter. That tissue needs to heal, and ligament tissue, much like the cuff, the rotator cuff that Dr. Javernick was talking about, it's going to take quite a bit of time to get that to scar down and heal well. And so they're on a much more prolonged recovery. You may get a patient like this with ulnarly based wrist pain, a 21-year-old player who's been playing for 3 months. He had a checked swing and he has pain in the ulnar palmar hand. He can't put weight through it, and he and his trainer thought it was a sprain and did some bracing and typical early stuff. His x-rays were normal on a standard view. Turns out he hurts right over the hamate, and he's fractured the hook of the hamate. If we look at these in a little bit more detail, it's typically delayed, like this patient, when they present. They may have a history of impact to the hand or a checked swing, and they'll have pain in this hypothenar region. They may have numbness and tingling in their ring and small fingers, and rarely they can have an attritional tear of their small finger flexor digitorum profundus as it comes around the hook, kind of like a pulley there. You need a high index of suspicion for a hook of hamate diagnosis. You can get a CT scan, it shows it well. You can get a carpal tunnel view x-ray, which also can show it. But again, you need the index of suspicion because you're not going to see it on standard views in the ER. You can try a period of immobilization. They're often going to come to our clinic after they've already done that. Some surgeons will repair this, but these are notorious for not being able to heal because of their blood supply and delaying the recovery. I think the standard of care among people who treat athletes with this is to excise the hook of the hamate. This is a kid who showed up after a couple of months last year, and 4 weeks after we took out the hook of the hamate, he was able to play baseball. He's celebrating after a stand-up double that got them to the College World Series just 4 weeks after that surgery. So that kind of accelerated return to play is important to consider, and we will not typically see that they have long-term deficits from that, although there have been some biomechanical studies that suggest there may be. This kid sure doesn't think that's the case. Skiers' thumbs will typically present classically with skiing or a fall to the thumb while planting in basketball or football, and it's a thumb abduction injury. The key to this is the clinical exam. We place a radial stress across the MCP joint and 0 and 30 degrees of flexion to get both components of that collateral ligament. What's important here is to understand what's normal for them, and you want to compare to their contralateral side. So if they have laxity greater than 30 degrees, it's probably torn. If they have laxity 15 degrees more than the contralateral side, it's probably torn, or if you just don't feel an endpoint, it's torn. A lot of these patients are too sore to get a good exam on, so you may need to do an anesthetic injection to block that pain signal. MRI is always a good option if you're uncertain with these. In a young adolescent athlete or even an off-season athlete that has a very stable partial tear, these can be treated in a cast for 4 to 6 weeks, followed by a short range of motion and therapy session, and get them back in protected orthosis. If they're unstable and they're young, you can probably treat them in a cast, but an older athlete is going to want the predictability and the success of a repair of this ligament. Multiple ways to treat this. I think over the last couple of years, the technology has advanced dramatically for this injury, and typically we'll use some kind of suture augmentation and anchor to repair the ligament to give it a biological and a synthetic protective element. We can get them back moving within 2 weeks. We can typically get them to play in some athletic situations in 6 weeks, maybe just a little gutter brace at that point. Certainly with any kind of sports, you're going to see bony injury. We certainly don't have the time in this talk to discuss every iteration of bony fracture you'll see in the hand and wrist, but some overriding principles are important. Obviously, X-ray will be the mainstay of your radiographic workup, sometimes a CT scan for intra-articular or complex injuries. And the important thing is that many fractures can be treated non-operatively, but we have to make sure that the digital cascade when the patient makes a fist is appropriate. There's no malrotation, and as those fingers come down, they're all kind of converging towards that scaphoid pole in the palmar aspect. Certainly unstable injuries need to be fixed, and in some cases we can get an athlete back faster with bony stabilization surgery. Metacarpal shaft fractures are very often stable and don't need to be fixed. There's various degrees of acceptable alignments, but again, the key is, can they make a fist, or can they suggest a fist, because many times they're stiff. Can they suggest a fist with appropriate cascade and without rotation? Wires, screws, plates, and other constructs can be utilized in the patients who are unstable or need to be fixed. Some of these are pretty stout implants. A patient with this implant could potentially go back to play as soon as the wound is healed, maybe with a little gutter orthosis, or perhaps a slightly bigger, more protective orthosis, but we can get these guys back pretty rapidly if it's a stable fixation. From the community perspective, the question is always, does the position of the splint matter? The age-old adage was that we should put these people in intrinsic plus positioning. But there have been several studies that for the limited time that patients are going to be splinted, it doesn't seem to matter in their outcome. So rather than forcing a patient into an uncomfortable position, it's okay to put them in a position of comfort and get the subspecialty care they need and with definitive treatment at that point. There may be situations such as after surgery or for specific fracture patterns that need a different kind of position, but you don't have to stress out about intrinsic plus positioning. Phalangeal fractures, metacarpal fractures, again, multiple ways to fix these, but the key is that we want to stabilize the hand, make sure that we can get a patient to therapy quickly and start moving them to accelerate their rehab. You may come into more contact with the distal phalanx fractures. Most of these are non-surgical and can be treated with clam shells, allumifoams, or stack splints, but you need to watch out for the Seymour injury in a young athlete. They may get hit with a softball or a baseball, and this is a Salter-Harris 2 fracture that technically is open. And we most often will treat these surgically with some urgency just to prevent osteomyelitis or defects to the growth plate and nail bed. Most of the time you're going to see a lot of jammed fingers, and this is always the challenge in a subspecialty hand clinic is jammed fingers are sometimes sent in and it's truly a jammed finger, and other times they don't come in for 3 months and it's a catastrophic injury that looks pretty normal on clinical exam. So I think the key here is that jams, if they're not making rapid improvements in their motion, they need an x-ray, even if there's no obvious deformity. And don't be afraid to run these by. There's no jam so simple that you can't text me or one of my other partners and ask us if it's all right to treat that with buddy straps. In this community, we see a lot of Pulley ruptures, although I will tell you that the climbing community often self-treats these. They're accustomed to them, they know what to do. And it's typically the A2 pulley, sometimes the A4, and they'll have acute onset volar pain. They'll feel a pop, some swelling, and have trouble actually flexing. They may have a little bit of a lag or some bowstringing. The majority of these we can treat non-operatively. And most of the climbers never make it into our door because they know to put on a ring splint or small little tape strips to act as an extrinsic pulley until they heal. The only time we really get into surgical reconstruction is if there are multiple pulleys, and those are complex, challenging endeavors. The jersey finger is not uncommon, particularly in the fall with tackling football or rugby players, which causes a forced extension of the DIP joint. The ring finger seems to be most susceptible. We'll see it in basketball players as well as they come down from a dunk and get their finger hung up in the net. These patients typically can't flex the DIP joint actively. An x-ray may show that there's a small avulsion fragment. Sometimes the tendon stays put out by the DIP joint. Other times it retracts all the way into the palm. Those are much more serious and we need to get to those pretty urgently. But most of these, almost in all cases, are going to be fixed surgically. We treat them early, we advance the tendon edge and anchor it back to the bone or perform some other construct to keep the tendon where it can heal back. Sort of the reverse of that is the mallet finger. And this is also known as the baseball finger because a patient may get hit with a softball while fielding a grounder and it causes an acute droop. Sometimes patients aren't even aware of when this happened. It's not always painful, but they can't extend actively. You do need an x-ray with these because sometimes there's subluxation of the joint and sometimes there's a bony fragment that needs to be reduced. The majority of these, even in athletes, can be treated with a brace, but the key here is that you need significant compliance. Those braces need to be on 24/7, and if the brace comes off and the finger droops, time starts over because they're disrupting that healing. In some cases, we'll treat these surgically for patients, perhaps, who are getting their hands wet and can't keep the brace on. They have poor compliance. Or on occasion, we have a CSU receiver who has to play Saturday, but they're going to get a pretty big pin in there because we don't want that to fracture or bend or cause future issues. I'd say it's more rare to be pinning these even in athletes. So here we've seen a bit of a buffet of all of these, but the question is, how do you get these athletes back and when is it safe? And so with sprains, strains, and contusions, I think they need to have pretty close to full mobility. They need to have good motion. They should be able to make a full fist and have full wrist flexion, extension, pronation, and supination. Their grip strength should be pretty good. They might not be 100%, but you should be able to demonstrate good grip strength. And a simple thing is, can they do a burpee? Can they do a push-up? And will they favor that wrist or that hand in that case? If all that criteria is satisfied, I think it's reasonable to get them out to unrestricted play. For fractures, they can't have tenderness over the fracture site anymore. You need to see that there's radiographic healing, and they need to fulfill the previous criteria. It's a little bit different with surgeries, ligaments, and reconstruction, and will be sort of in concert with the surgeon. It's definitely dependent on the sport, the athlete, and ligaments heal slow, so they're going to need time. So I think we've been able to go over a lot of athletic injuries in a pretty rapid amount of time. We're going to see different treatment principles. We want to get an athlete back faster, but ultimately it's a risk-benefit discussion. These athletes want to play. Their parents or their coaches may want to play, but as a provider, your ultimate job is to make sure that that athlete is getting the best care that will serve them currently and in the future. That means you might get them out to play. You might have a slightly higher risk of re-injury, but that needs to be discussed. We're certainly not going to play with pins across the joint. We can play sometimes with other forms of fixation, with the exception of a mallet finger. Some of them will play with a pin, but generally no pins. We want the wound to be healed before they're playing, even in a cast. Each individual needs a specialized plan based on their age, what their future desires and dreams are, what position they play, what type of the season they're in, and ultimately, you have to work through these dynamics of the parent, the athlete, and the provider. Thank you for letting me speak to you today. I'm happy to take any questions. And I think Carly's hovering here because it is snack time. So I think we're going to reconvene at about a half hour.
Yeah. Thank you, Dr. Peterson.
Yeah.